So Dr. Jessica is an associate attending physician in the Division of Rheumatology at a hospital for special surgery and an associate professor of clinical medicine as well. So she specializes in the treatment of patients with systemic sclerosis, and her research focus is developing improved outcomes and measures and therapies for patients with the condition. So Dr. Gordon completed her undergraduate studies at Brown University in '93, and she received her MD degree from State University in New York at Stony Brook, where she graduated Alpha Omega Alpha. She completed her internal medicine residency and chief residency at Georgetown University Hospital in Washington, D.C., and then went on to complete her fellowship in rheumatology at a hospital for special surgery. Following this, she joined the faculty at HSS in 2010, where she continues to practice rheumatology. So Dr. Gordon conducts clinical and translational research in scleroderma, and she's an investigator in multiple clinical trials and observational studies with this focus. She's been the recipient of numerous grants and awards, including the Kellen Family Clinical Scientist Development Award and the Scleroderma Foundation New Investigator Grant, the Charles L. Christian Award for Excellence in Musculoskeletal Research, and the American College of Rheumatology Distinguished Fellow Award. So that's a lot of awards. So we're very privileged to have you as our guest speaker today with all of that and your specialty in scleroderma.
Okay, great.
So you just tell me next page when you're ready.
So we can start off. If you could go to the next one, great. So this really, I just caught the end of what Louise was talking about, but this talk I think should go pretty well with some of the topics that I heard. I'm going to go through a lot of the testing that's done in scleroderma and in systemic sclerosis. And the goal is really to give you a basis of what your doctors are looking at to just help prepare you to be your own best advocate. And I don't know how it is. I guess the group here is from Australia and New Zealand, and at least somebody's from Canada. So we're all in different health systems. In the US, a lot of our health systems, we have a law that's relatively recent that requires all results to be available immediately to patients. So all of our health systems have set up like online portals, and patients can see their blood tests when they result, and they have access to all of this information. How is it where you are? Do you get that too?
We have, you can have all your results uploaded to your My Health, so that any doctor can see what's going on. Yeah.
Great. Yeah. So okay. So I think sometimes we have like a lot of, so this will prepare you to help interpret those tests all by yourself, but also definitely chat with your doctors. So we can go to the next slide. And with testing can be diagnostic, or sometimes it's prognostic, meaning like when you have X results, we know that there's a higher odds of developing Y. And then many of the tests that we do are used to follow disease over time. So we can go to the next slide. And the next one. So I'll start with a case that might sound familiar just to kind of anchor us. So a 50-year-old woman referred to rheumatologist. She had seen her GP previously for hand swelling and was noted to have a positive ANA. And she notes for 6 months, her fingers changed color in the cold, as well as reflux and cough. and changes in the skin and the hands and the wrists. So this would be like a familiar case maybe to this group. So we could have the next slide. And then when the physician examines her, they're looking at vital signs, listening to lungs and heart, looking for swelling, and looking for other aspects, especially on the skin and musculoskeletal exam. So we'll go to the next slide. And these are some photographs that maybe the physician is seeing. I think our group is going to recognize the Raynaud phenomenon in the bottom right. The top left shows puffy fingers and the start of skin swelling, skin thickening. And then in the upper right, we see salt and pepper changes, so some dark areas and light areas, pigment changes in the skin. And in the bottom left, we see a gentleman with telangiectasia on the face. So these would all be things that we could pick up on exam that your rheumatologist would certainly note. Go to the next slide. And nail fold capillaroscopy might be done by a trained rheumatologist. So if you're having nail fold capillaroscopy done, this is likely to be a rheumatologist with a specific interest in scleroderma. And if we look at these photographs, Louise, I'm going to have you go to the next slide and then we'll come back to this one. So these are different ways that doctors can look at the tiny, tiny blood vessels just around the finger, like you see focused in the photos. Some different techniques for it. The one in the top right is a dermatoscope. This is what I use. It's very simple and I can just have it in my pocket and it takes 1 second. It's really low maintenance, but it only gives a magnification up to 10 times. So the contraption at the bottom, which is, it probably that photo is about 10 years old. There are some better devices now, but it's not that old. But that type of device will give 200 to 600 times, and that would be used for more like research. So if you go back to the previous slide, the doctor would, this is really a sclerodermatologist at this point. They're able to look at these patterns. So the top left is normal. And then all the other patterns can be seen in different stages in scleroderma. So the panel B shows dilated nail fold capillary loops. And you can see how some of them are really much wider in diameter. The next one, C, shows dilation and some hemorrhage that would be like in the cuticle that would be seen. And then in D, we see somebody who's had scleroderma for a very long time and has had loss of some of those blood vessels over that time, and we would say capillary dropout. So we can go to 2 slides from here. And these are our classification criteria for systemic sclerosis. So this is my point here is that these are the criteria we use to make such a clear diagnosis of systemic sclerosis that this individual could be enrolled in a clinical trial or in a clinical study that we're certain that this individual has systemic sclerosis. So these criteria, if we take a minute to look at them, a lot of them are really related to the physical exam or to the history. So skin thickening, puffy fingers, changes in the fingers, ulcers on the fingers or scars from ulcers, telangiectasia, and those abnormal nail fold capillaries and Raynaud phenomenon. These are really all things that would be seen just on an exam. PAH or interstitial lung disease, it would be unlikely that you could make that diagnosis on exam. Even if you saw some signs, you'd have to do additional diagnostic testing to confirm. And the scleroderma-related autoantibodies obviously are blood tests. So a lot of the diagnosis of scleroderma can be made just on physical exam. And so it is really important to, for individuals who are at that, first sort of stage to wind up in a rheumatologist's office who might be the individual who'd be able to really pick that up. Okay, so we can go to the next slide. All right, and I'm sure many here have had the experience of having a million blood tubes drawn. And it's like, so let's talk about lab work a little bit. These are some tests that are done generally. And so like, and a lot of these tests are going to be done over and over again. So a CBC, I wrote, but a complete blood count or a metabolic panel and a metabolic panel. So those are going to be tests that look to see in a CBC or complete blood count, if your white blood cell count is normal, your hemoglobin is normal, your platelets are normal. In the metabolic panel, there's a look at electrolytes, kidney function, and liver function. And these really very basic panels are essential to understanding, are we having any complications of our medical therapies? How's the health of the internal organs? What kind of things are going on here? So you get these tests, depending on your meds, you may be getting them every 3 months. Muscle enzymes like a creatine kinase or aldolase, those are important in looking at muscle inflammation, which impacts a lot of folks with scleroderma. We look at urinalysis for protein, the ESR, CRP, so erythrocyte sedimentation rate and C-reactive protein are inflammatory markers that might be followed. Louise had brought up BNP, and that is done as well sometimes. In my practice, I don't order that one all the time, but it is a good idea in terms of screening for pulmonary hypertension. And then autoantibodies are generally done at the beginning and aren't necessarily done frequently. So I want to talk about those a little bit because I think those are interesting, and a lot of times folks have questions. And then Tara, thank you for translating so that I can keep it pertinent. So a CBC is an FBC. UNE is urine and electrolytes.
Yeah, it's your urea and erythrocyte.
Urea and electrolytes.
And
okay.
Liver function test. Yeah.
Yes. So we say LFT. Awesome. All right. Great. Thank you. Okay. Great. So let's go to the next slide. Okay. And so I'm going to talk a little bit about autoantibodies and definitely ask questions as we go. So an ANA is an antinuclear antibody, and this is a screening test that's done in the U.S. Like a lot of GPs will run an ANA if they wonder if their patient might have something autoimmune. If you Google ANA, it basically will lead you to believe that an ANA equals lupus, which is not correct. About 20% of the population, give or take, will have a positive ANA, and it depends on the technique that's used to test, and there are different techniques. But it is it is a screening test, and it can be very helpful in leading to the correct diagnosis. But it also, there are caveats to it, and it isn't a test that needs to be done regularly. You don't need your ANA level checked over time. It's usually done just in the beginning. So some scleroderma specific autoantibodies, the ones that are used in the classification criteria are anti-SCL70, which is also known as anti-topoisomerase, anti-centromere, and anti-RNA polymerase 3. And we'll talk about everything in more detail. Anti-U1RNP is another test that can be seen in scleroderma, but specifically when we see overlap or mixed connective tissue disease, we might see that one positive. And then when I'm assessing my patients, again, in the beginning, not necessarily every time, I do check for overlap with other connective tissue diseases, because that does sometimes happen. We can see overlap with Sjogren's syndrome, so RO-LA, sometimes referred to as SSA or SSV, can be positive. Blood tests associated with rheumatoid arthritis include the rheumatoid factor or an anti-CCP, anti-citrullonated cyclic protein. Lupus, we can see anti-double-stranded DNA, anti-Smith. Antiphospholipid syndrome, which is a syndrome that leads to increased risk for blood clots and pregnancy losses, can have those blood tests, the anti-cardiolipin, anti-beta-2 glycoprotein 1, and lupus anticoagulant. And others that we see less frequently in scleroderma include PMSCL, U3RNP, and THTO. So I'm going to go through these in a little bit more detail. Yes, Leslie. She raised a hand. I saw that go up.
Can I just ask, you said something about blood clots there
Yeah.
a minute ago. Can you explain that a little bit?
Mm-hmm. So there's a syndrome that's seen in individuals, a separate rheumatologic syndrome, okay? And it's called antiphospholipid antibody syndrome. And people who have this condition, which is different than scleroderma, but they're cared for by rheumatologists, they have these blood tests, the anticardiolipin, anti-beta-2 glycoprotein 1, lupus anticoagulant, so they can have those. And they have clinical events, which could include blood clots, like a blood clot in the leg or in the lung. And then, some folks with this syndrome have miscarriages, and that results from blood clots in the placenta during pregnancy. And this condition is treated, there's more complexity to it, but with anticoagulants or blood thinners. But individuals with scleroderma can sometimes have these blood tests too, even if they haven't had blood clots or pregnancy losses. And sometimes the folks who have these blood tests wind up getting like worse digital ulcers or other kind of like funny ulcers in different places. So I do think about these kind of overlap with other conditions that rheumatologists treat, because our conditions do overlap. There's a lot of common themes that we see, and so this is something that I tend to screen for, but maybe not everybody does.
Okay, I'm just interested because I've had a positive anti-centromere antibody test quite a long time ago, but I've just ended up in hospital with blood clots on my lungs, lots of them, and they don't know what caused them. They were looking for
cancer. They may have
cells.
checked for these, and so they may have. So you could ask your doctors if they had. If they had checked for them and they were positive, they would make sure to keep you on a blood thinner for a long time. Whereas if there was something else that was known to be the reason for it, I don't know, maybe you had a surgery or some other inciting event that caused it, then maybe you would be on blood thinners for a shorter period of time.
Yeah, no, there was no reason for it, really. They couldn't find a reason for it. They did say I had an autoimmune disease, but it's all
Okay.
pretty
Yeah.
fairy.
Yeah. Okay. And then
Yeah.
Tara shared that she's on anticoagulants. And I think there were some other questions. Okay, I'm going to go through
Thank
ANA
you.
in more detail too. Okay. So Louise, if we can go to the next slide. Okay, so this is the ANA test. So we're going to get a little bit technical. Blood is taken and the blood's separated by putting it in a big centrifuge, and it's spun down into serum and blood cells. So the serum has all proteins in it, like all of the antibodies, and that's diluted. And then they incubate it with either a specific cell line or specific antibodies, and sometimes they'll use special beads in a standardized test, and then so with the cell line, and then they add a fluorescinated antibody, and then you can visualize the cells under a microscope. And then there are different patterns. So I'll go to the next slide to show those patterns. This is what it would look like under the microscope. So and these patterns have different names, as you see: peripheral, diffuse, speckled, nucleolar are some patterns. And then each of these patterns have clinical associations. Louise, if you go to the next slide, we'll see centromere. That's what centromere looks like, and it's because the autoantibody binds to the centromere protein, which is important in cell division. Okay, so you could see it under a microscope, but nowadays it's done in an automated way in labs. But you might also see in your lab results an ANA done by immunofluorescence. This is basically showing you what immunofluorescence looks like. And then these different patterns have different clinical associations. And at one time, that was kind of like where it ended. But over the years, we've learned a lot. So now we can see what is the specific proteins that different antibodies are directed against. So we can go to the next slide. So there are a lot. So that's the ANA test. And I can stop there to make sure I take any questions about ANA. Elizabeth, correct. ANA stands for anti-nuclear antibody. Yes. And then Gail, did you have a question? All right. Well, we'll come back to it if you come back later. All right. Okay, so in scleroderma, we see an ANA positive in about 95% of patients. So that means about 5% of folks with scleroderma are ANA negative. And there are scleroderma-specific autoantibodies. A couple of things about them in general. Usually, it doesn't switch. So if you had a positive centromere, you are very likely to always have a positive centromere and not switch to a positive SCL70. That really would be not something we would see. And usually only one is positive. So if you had an anticentromere, it would be very unlikely to have also a positive SCL70. And I always say usually because there's always an exception to the rule. So we do sometimes see 2 autoantibodies, but it's very, very unusual, like less than around like 2%, give or take. Okay. And usually one is sort of dominant. In general, we don't really follow the levels of them. So these are important in diagnosis and prognosis, I'll show you. But the level doesn't correlate with activity of scleroderma. So let's say you felt like you were flaring, or you were in a period of change where disease was active, we wouldn't expect to see a higher level of the SCL70 and wouldn't need to look for that. It just isn't generally seen. Now, I always think we're learning more, so I'm gonna, parenthesize everything with a caveat. Maybe in the future, if we develop a therapy that is curative, maybe I'll have another, I hope, then maybe I'll have another tune and we'll see these kinds of antibodies go away. But at this point in your general care, we usually don't see them switching up or changing level, which is different than a condition like lupus, where there are certain antibodies in lupus that'll go up and down with disease. So this is sort of the way we see it in scleroderma. So next slide. Okay, so this is a picture that looks at the proportional representation of antibody frequencies. And I like this slide, but it is a little busy and a little hard to take in. But if we think of, so folks with diffuse scleroderma, the diffuse versus limited is defined based on distribution of skin involvement. So somebody who has diffuse scleroderma is by definition will have skin thickness, either the upper arms, the thighs, the chest, and the abdomen. So there's sort of, whereas somebody with limited, it's below the elbows, below the knees in terms of skin distribution. So we see if one has the centromere antibody, that is almost always seen in limited scleroderma. And if someone has the RNA polymerase III autoantibody, that is almost always seen in diffuse scleroderma. With the SCL70, also sometimes referred to as topoisomerase antibody, that is usually seen in diffuse scleroderma about 70% of the time, but sometimes folks will have a limited scleroderma. But these autoantibodies wind up being important in prognosis because they predict what type of internal organ involvement could we expect. So they wind up being really powerful at the beginning to think of, where might we be going with this condition. So I'll go to the next slide for that. So this really looks at the different, it's small, so hopefully you guys have big screens. Some of these different autoantibodies and their clinical associations. So like anticentromere, seen in limited systemic sclerosis and clinically associated with pulmonary arterial hypertension as the most significant internal organ involvement. But I do want to say that'll only happen in about 10 to 15% of folks who have limited scleroderma. So it doesn't mean you're going to get that, but your odds are of that complication can be defined. So, so that's just important for us to know, and we're going to make sure we do the echo and the pulmonary function test every year, or however frequently you're getting it. Here we do it about every year. And that is going to be how we're attentive to screen for it. We catch it early and we treat early and we do better. So with anti-topoisomerase, So that is, like we talked about, seen more frequently in diffuse, and folks with that will have about a 70% risk of pulmonary fibrosis, and over their, lifetime. But that is something we're going to make sure we're screening for and really looking for. And there can be cardiac involvement, RNA polymerase 3, diffuse, and folks who, although that blood test is seen in about, give or take, 20% of folks with scleroderma, folks who have the RNA polymerase 3 antibody have an associated higher risk of renal crisis. And they're more likely to have severe skin and musculoskeletal involvement. So we do frequently see this. And then we also list some of the other less commonly seen antibodies as well as their clinical associations. And with a table like this, it's a simplification, and it definitely doesn't mean that if you have this, you will get X, but it does increase odds, and helps us focus where we're really going to emphasize screening and testing and things like that. We can go to the next slide. And I won't go through details on this slide, but I do want to note that we have seen that the frequency of the various autoantibodies varies depending on where in the world we are. So, for example, if we look at anti-RNA polymerase 3, if you look at different cohorts, so most of the European cohorts, like 2% in U-star, which is multiple different countries, 6 to 9% in France, 6% in Belgium, 47% in Germany, 17% in the UK. In the US, we see, this is just looking specifically at the Pittsburgh cohort, which is a very big cohort in the US, 22% there. If we look in Asia, 6 to 10% in a Japanese cohort, and in Australia was seen 13 to 15%. And the reason the specific places were chosen just depended on where the cohorts were that they were looking at it, that they had data for this study. So you can see, these different trends. It's interesting, but if you're thinking about clinical trials that are going to go, that are in multiple countries, it is important to realize that maybe certain phenotypes or certain ways of presenting in scleroderma are going to be more common in some areas than others. So we can go to the next one. So we'll talk a little bit about various organ involvement, and we'll get through a couple of different organs. Okay, not everything. So if we go to the next slide. So a lot of additional testing is done, as you're totally aware of already, and we'll go through some of this. The next slide. So in terms of assessing the kidneys, so we talked a little bit about scleroderma renal crisis. This is a complication that can be seen maybe in around 5% of patients. But if it's an individual who has the RNA polymerase 3 antibody, maybe there's about a 20% risk of it in those individuals. And it's a very serious complication, but it's one that we have excellent treatment for. So in scleroderma renal crisis, the blood pressure gets very high out of nowhere, and there can be impact on kidney function. So the way we assess kidneys is pretty simple. It's with blood pressure measurement. So I used to write a prescription. Now I just tell my patients to go to the drugstore to pick up a blood pressure cuff. And I have them monitor their blood pressure at home on their own. And their blood pressure should always be normal. And so normal is, so over 140, over 90 would be high. And so less than that between 130 to 140, and then 80 to 90 is maybe borderline. And then under 130 to 80, that's normal. But, you know, where are you starting is really important. Maybe I'll have a, you know, woman who weighs 100 pounds in my office, and her blood pressure, maybe she's like, I don't know, 25 years old and 100 pounds. And her blood pressure, when it's normal, may be 90/60, which is low. So if her blood pressure out of nowhere was 130/80, that would be a significant change. So it is important where you're starting to. Or maybe I'll see a patient who's a 55-year-old woman, and she has had high blood pressure for 20 years and a new diagnosis of scleroderma. You know, I'm going to be less worried when her blood pressure is 140/90, because she's always had high blood pressure. That's where she runs. So there's a lot of individual interpretation here. So I make my patients write down their blood pressure and show it to me at our follow-up visits, because it's the only way to actually, no one remembers what the readings are, and we all tend to sort of, you know, remember the normal ones and not anything out of range. So we do that. And then on lab tests, we'll look at the creatinine, and we look at a urinalysis to tell us if there's protein in the urine. I don't have on this slide, if there's a high suspicion of renal crisis, we can check a blood test called the renin. And that's another helpful clue if that's very high. So we can go to the next slide. And if I'm short on time, I can always wrap up. So give me a heads up if I can definitely, whenever, we'll get to wherever we get. In terms of monitoring lungs, we screen for pulmonary fibrosis with pulmonary function tests, and a CT of the chest, or a high resolution CT of the chest, is very helpful to do as well. And when we're looking for pulmonary hypertension, which is high blood pressure in the blood vessels that lead to the lungs, we use an echocardiogram, and pulmonary function tests are helpful there too. So let's look at a little bit more of these studies. So the next slide. Okay, so I bet everyone in this group has had a pulmonary function test, and you could teach me a thing or two about having these tests. So we'll go to the next slide. And this is what one might look like for your physician who's interpreting it. So, so we look at this page, and there's a lot of letters and a lot of numbers. And maybe we don't need to know what every letter and every number means. So let's go to the next slide for the important ones. Okay, so these are the ones I want you to look at when you're looking at your own pulmonary function tests. So the forced vital capacity, or the FVC, is the amount of air. It's just a volume. So it's expressed in either liters or milliliters. And it's the amount of air exhaled forcefully and quickly after inhaling as much as you can. The total lung capacity is the total volume of the lungs when filled with as much air as possible. And then the diffusion capacity measures how well oxygen moves from your lungs to the blood. And it varies with the amount of surface area in your alveoli. So in the lungs, they go from big airways to small airways to tiny little structures where oxygen molecules cross into blood vessels. Those are alveoli. And so how many alveoli you have matters. How open they are matters. So that's the surface area. How much blood is in your capillary. So if you have anemia or like a low hemoglobin, your DLCO is lower. So that is important to keep in mind. And then the thickness of the membrane between the alveoli and the capillary. So if one had interstitial lung disease, that membrane is a bit thicker, and that impacts the DLCO. And if there's excess fluid in the alveoli, that also impacts this measurement. So somebody who had interstitial lung disease, and this is being done due to interstitial lung disease, if they also had pneumonia or they also had heart failure or something that was leading to fluid in the lungs, it wouldn't be a good time to do this test. Okay, so let's go to the next slide. Okay, so this is back to our sample pulmonary function test. So let's look at the line that says FVC. The L means it's measured in liters, and there's a reference value. So that reference value depends on your age, your height, your sex, whether you smoke. It can vary with race as well. So when you go for your PFTs, they're probably asking you all those kinds of questions, and they put that into their algorithm. And then, so that's the reference value. And then there's a measured value, and then we see the percent of the reference value. So this individual's FVC is 54% predicted. Okay. Same with the total lung capacity. This individual's is 63%. And then if we look at the diffusion capacity, this is the same idea. This one is 64%. So we see reduction in all those three areas. That's a pattern that it is consistent with restrictive lung disease like interstitial lung disease. Now, if we saw the FVC was 100% and the total lung capacity was 100%, but the diffusion capacity was low, like 50%, that is a pattern that we might think of pulmonary vascular disease. So something like pulmonary hypertension, and we're looking at the PFT. And then we're also, well, here my pulmonary lab didn't have a hemoglobin concentration, but you can perform like an algorithm, and you can correct a DLCO for a change in hemoglobin if you're anemic or something like that. So if we go to the next slide, and then we won't worry about the curves. Those can be used by pulmonologists to help figure out different patterns. So it would look different if an individual had asthma, for example. But I want to show at the bottom that we can track these values over time, and it becomes very important and useful for us. So this individual's FVC lowered from 2.17 to 1.99. That would be a pretty small amount, probably not clinically significant. And their diffusion capacity also lowered. So if you're seeing that kind of trend, then you ask, what's causing this? Maybe they had a bad day. It's hard to do these tests. Do we repeat it and make sure this is correct? Do we do a CT, something like that, to see if interstitial lung disease is progressing? So the PFT is super important and good to follow over time. Other caveats with this testing, it matters if it's the same machine or not. There's a lot of things that can go into it. So if you move from one city to another and you're going to a different center, we can see sort of changes from one machine to another. If we look at the raw values, we do our best to continue to trend it. But you wouldn't, if you had the option of going to the same place, it's better to do that. It matters if the technician coaches you to really give your best effort. It matters. And we can see changes, not only in a negative way, like I'm showing you in the example here, sort of, but we can see changes in positive ways too. We can see FVC and diffusion capacity improve with treatment. And you can also see these measurements improve with conditioning and other things like that. So it's always impressive to me. And you don't have to like run a marathon, but cardiovascular conditioning or even yoga, which is a breathing exercise, depending on what you're doing, can impact these parameters in a beneficial way. So we'll go to the next slide. This is a chest X-ray. We don't really get that much info from them. So I'm going to go to the next. But in the U.S., sometimes you have to order a chest X-ray before the insurance will approve a CT of the chest. That's how we do. But as I'll sometimes see somebody say, "Well, I had a chest X-ray, and so I know I don't have interstitial lung disease," but a chest X-ray isn't sensitive enough to rule that out. CTs of the chest are done in folks at risk for interstitial lung disease. Most of the time we're doing them in anyone with diffuse scleroderma, and maybe following them over time. On the left, we see a normal CT of the chest. On the right, we see an individual who has interstitial lung disease with, at the bottom, we see ground glass opacities, and we see some dilation of the airways, the bronchioles, and that sort of black, I guess, kind of like oval shape in the center is a dilated esophagus. So you can see a lot, and we like specific protocols for CTs of the chest. So we like to look at high resolution CTs of the chest, which really gives us the best assessment of interstitial lung disease. Those can be followed over time, and we can see progression or improvement, and a lot of other pathology can be seen as well. Sometimes we'll see nodules that need to be followed. Sometimes we'll pick up cancers with these tests as well. So we can go to the next. So in terms of assessing cardiac involvement, EKGs are done, and so are echocardiograms. So we can go to the next slide. This is just a normal EKG, and nothing, but we're able to look at rhythm and different measurements that are helpful, and then we can go to the next. So then this is an echocardiogram, which gives us a ton of information, and this would be a test that we'd be doing every year. The next slide. And this is what a typical report would look like. There's a ton of information. This lucky patient is normal, but in terms of focusing, the report gives us a full, a lot of assessment of all the valves and all the anatomy of the heart. But in general, if we're, some of the measurements that are very important are the ejection fraction, which lets us know how well the heart is pumping. And then we also look at the PA systolic pressure, which is sometimes read as the right ventricular systolic pressure. And that should be less than 36 millimeters of mercury, and then that is normal if it's less than that. The way PA pressure is measured in the heart relies on an echocardiogram. It relies on a lot of assumptions, like mathematical assumptions, and it relies on if the technician can get a good view of blood flowing through the tricuspid valve, there has to be some backflow or regurgitation through that valve in order to do the measurement. So it's actually kind of a tricky measurement, and you don't always get a reliable value from an echocardiogram. And in some studies, it shows that the echoes can be wrong on PA pressure half the time. So that is a lot. So this is not a be all end all, and your rheumatologist is going to look at a lot of all the other info on this to look. If you go to the next slide, there'll be a discussion on the right ventricle. So the right ventricle is the part of the heart that pumps through the pulmonary artery. If the right ventricle was not pumping normally, so showed like reduced function, that might be a sign. Or if it was dilated, that could be a sign, and you might not see the pulmonary artery systolic pressure measured. So we do have to really look at this test. So when you have a high degree of suspicion for pulmonary hypertension, that's where that measurement of the BNP or NT-proBNP can be helpful. And if that value of the blood test is high, then we can, then that also increases odds and might lead your doctor to refer you for further testing. So the echo is used just for screening, but in order to really make a diagnosis of pulmonary hypertension, you need a right heart catheterization, which is a test where it's an invasive test where a wire is threaded, a catheter through the vessels to measure the pressure directly in the right heart, and that is the way you could really make a diagnosis. Okay, so let me take a pause and look at what's in the chat. So Tara said that she started singing and that helped her PFTs. So Tara, I hope you have a good voice, or no, I'm just teasing. And
I won't give you an example.
and then okay, so and then Diane asked, how often should we monitor our blood pressure at home? So that's a great question. In terms of what I recommend, so there's not just like one rule for that. So it sort of depends on other things going on. So like I told you, I work in New York City, and it is true in New York, people are very anxious. We're all crazy. So I don't want to contribute to the anxiety that my patients are already dealing with when they're dealing with new medical diagnoses and all the stuff that's being thrown at them. And we were all anxious just at our baseline anyway. But so I keep that in mind. So if my patient has like so the kidney issue, the renal crisis is more likely to happen at the onset of scleroderma. So much more likely to happen in the first 3 years or so than it is after, let's say, 10 years or much later. It's more likely to happen if you need to treat with prednisone. So prednisone at doses higher than 10 milligrams are associated with increased risk of scleroderma renal crisis. And that RNA polymerase 3 antibody or the SCL70 antibody can be associated with it. And in patients with diffuse scleroderma, those are all risk factors. So if my patient has all those risks and their blood pressure is normal at baseline, then I may tell them to monitor every 3 times a week, but write it down, okay? And it should always be normal. If you have a cup of coffee, it shouldn't make your blood pressure high. It's just, and I'm only saying this because this is something I hear all the time. If your spouse, I don't know, made you mad, maybe that would increase it a little bit, but it should come back to normal. So we're not going to look for reasons for it. We're going to look at the value and check it. I mean, the machines aren't perfect, so it is a good idea to check it against the machine at your doctor's office. You could just bring it in and make sure the measurements correlate. So, but if somebody had like some of those risks, I'll have them do it 3 times a week. If they have a lot of those risks, maybe once a day. But if they, let's say they're in my office and their blood pressure is very high and I'm starting medicines and I'm worried about their blood pressure, then I might be having them check it several times a day to make sure we're actually treating it. So it really depends on what's going on. Same with like the frequency of creatinine. If you're low risk, you don't need to be checked all the time. But if you're at a higher risk, the blood pressure is really the thing that needs to be monitored, and then the creatinine might, might be checked when the blood pressure, if the blood pressure got high or something.
Thank you.
All right. Can you have repeat? Oh, well, we'll stick with the renal crisis. So Sue asked, can you have repeat renal crisis episodes? You can, and again, it depends. So if we see these issues, the high blood pressure, maybe the creatinine going up, we start a class of medicines called ACE inhibitors. So like lisinopril might be one, or captopril might be one that we would start. And then in that kind of scenario, then we're checking blood pressure several times a day and making sure it comes down to normal. And if it remains high, we're titrating up that dose or adding other blood pressure medicines to make sure that blood pressure gets down. So if we're at one of these times where we're having high blood pressure, that's a lot of follow-up, a lot of checking at home, a lot of interaction and labs and things like that at that time to make sure we get it down. Like I wind up not admitting patients to the hospital unless something's going on, like they have massive headaches or there's other issues. I do this all kind of at home, and I'm emailing with my patients and just in constant contact with them. But in the past, folks would be admitted if they were having these kinds of issues. So if somebody had like real full-blown renal crisis, they really need to be on that ACE inhibitor forever. And maybe the dose changes over time as other things change. Maybe they don't need as high of a dose, but they really will need that. And if other issues come up, they could have a repeat episode. If they came off that medicine, they could have a repeat episode. So it is something that is important over time. Let me look at these other questions. So Tara also noted for vocal exercises that she found a great lung rehab. So that sounds wonderful. And then Therese notes, I also have rheumatoid arthritis and am anemic. Why can ferritin be artificially raised with RA? Okay, so ferritin is a measure of stored iron in the blood. So it does measure that, but it is also an inflammatory marker. So it's a protein made by the liver that is high in severe inflammation. So you do see it have these dual roles, and the So ferritin might be, if you had iron deficiency, so the ferritin was low, but a lot of inflammation from rheumatoid arthritis, the ferritin might wind up being a little bit high, but even could be not as high as you would expect with that inflammation. So that one is a little tricky. Can lung scarring on repeat CT mean ILD? So when you look at the CT for interstitial lung disease, you can see active inflammation, which the radiologist will read as ground glass, but they can also see scarring. And sometimes that scar is from the interstitial lung disease, so they might remark on lung fibrosis or honeycombing. Those would be words that would be used to describe the type of scarring. But you could also get lung scarring from other issues. So if you had pneumonia, like a bad pneumonia, even after it resolves, there could be a scar in the lungs. People who've had tuberculosis have a specific pattern of scarring in the lungs. So other kinds of things can cause scarring too. And usually the radiologist can look at patterns and help give a best guess on what that is from. And I feel like I hit the meat of the talk. I have a few more slides that we could go through, but if you just go to the next one. So yeah, I mean, the rest of it, I'll tell you what I have, and if we could, and I can do whatever he wants me to do, but I can either go through it or we could pause here and just have a conversation. I did put in a couple of slides about how skin is assessed. And this can be done in clinical practice or in clinical trials. And then I have just like 2 slides on GI evaluation. And that's pretty much it.
Well, we are conscious that we're keeping you over time, and it is very late for you. We're all in the middle of the day a little bit, so it's not so bad. I did have a look to see how many more slides were there. So it's really up to you, Jessica.
Well, why don't I just go? I'll go through them. I'll and then if there's anything interesting, just feel free to ask questions. So I tend to always go over. So skin, when we do trials in scleroderma, we do a clinical assessment of skin called the Modified Rodnan Skin Score. And sometimes in trials, we'll do skin biopsies. They're not usually needed in clinical practice, but sometimes they'll happen, sort of depending on the scenario. So this background of the slide is the skin biopsy of somebody who had scleroderma. So if we look at the next slide, this is this is like a form I might fill out for the Modified Rodnan Skin Score. So we check for skin thickness in 17 different areas of the body, and each area can be rated from 0, which would be normal, to 3, which would be severe skin thickening, and then 1 and 2 are in between. And we can use this to follow skin disease over time. If you go to the next slide, this is, this is a 20-year-old diagram, but it sort of shows a general pattern of how the Modified Rodnan Skin Score changes over time. And the top curve would be someone who has diffuse scleroderma, where we see it getting precipitously worse over the first maybe 2 years, and then over time slowly improving. And you might see a trend like that even without treating. And this can really vary, right? Some would have an improvement where the skin would come all the way almost back to normal, and others would be in between. Whereas in limited cutaneous scleroderma, there's not generally too much skin involvement initially, and then it never gets too bad even over time. And then the next slide just looks at a skin biopsy of how a skin biopsy looks different in somebody with scleroderma and someone who doesn't have scleroderma. All this pink on the left is collagen, and then you can see that it's so dense with the pink, whereas on the other slide, there's white space in between these kinds of whorls of collagen. And in that scleroderma skin, you don't see as many hair follicles or eccrine or like oil and sweat glands, and you see some effacement of normal fat in the skin too. So it gives us a lot of information where, but not that important in terms of clinical practice or following over time, but something that's very interesting when we're trying to learn more about scleroderma. So we can go to the next slide. And a lot of different tests for the GI tract. I could do a whole hour on this, so I won't. But you know, different assessments may be done. A barium swallow might show some dysmotility. There are more sophisticated tests we can do to measure esophageal dysmotility, like manometry, which you might have. Endoscopy and colonoscopy are very important. Endoscopy is a camera that goes through the mouth to the stomach, can look at, see ulcers, see severity of reflux, can screen for esophageal cancers or precancers, and in the stomach could see ulcers or watermelon stomach or gastric antrovascular ectasia, which folks with scleroderma are at risk for. Colonoscopy is important really in cancer screening and can be helpful in assessing if there's bleeding or other issues. Capsule endoscopy is done to look for bleeding or other issues in the small bowel. So this is very simplified and we can just skip through. This is a photo of a barium swallow, and I don't generally order these, but sometimes they are done. And then the next one is what gastric gave or watermelon stomach looks like on endoscopy. And I mean, to some gastroenterologists, this somehow looked like a watermelon. I think it's a stretch, but they name everything after food. So, all right, so we can, and I think the next slide is the, yeah. So yeah, again, really want to encourage everyone to engage with their results. I think it's helpful in terms of understanding what's going on and helping you to be your own best advocate. It doesn't always work for everyone. Sometimes it's hard to just deal with them. There's a lot of stress to look at that, and in those, and so you know, it's very individual. So I think for my patients who are having a hard time with it, then I think it's sometimes helpful to have somebody helping them. So either a family member or a trusted friend, if that's available. And then I think the next slide is just thank you. Yes. All right. Anyway, thank you so much for inviting me, and I'm happy to answer any questions.